This is the first presentation in CNS infection, number 1, prepared by Prof. Sharaf and revised by Prof. Rami Edward. Bacterial cerebritis may be hematogenous, contiguous, penetrating wound, or cardiopulmonary malfunction. Hematogenous, contiguous, like mastocytitis, penetrating wound like in trauma, cardiopulmonary malfunction. Bacterial meningitis complications, spread of infection, subdural effusion, empyema, cerebritis with abscess formation, pyocephalus, cerebrovascular vasculitis, as ischemic changes and infarct, disruption of the CSF with hydrocephalus. These are the famous complications of infection. Now, what is an abscess? May be solitary, may be multilocular. CT and MRI show contrast enhancing low density lesions surrounding with vasogenic edema. MR spectroscopy shows the elevated lactate peak. The complications: intraventricular rupture, choroid plexusitis, leptomeningitis, or daughter abscesses. Now, this is cerebritis at late stage, starting to accumulate and form an abscess. This is early and late cerebritis. Here, start, edema, localization, and start to form the abscess formation. The difference between these two is 2 weeks interval. Multiple abscesses here and there. The smooth outline, the smooth inside, the smooth outside. Don't forget that abscess could be multilocular. Biogenic cerebral abscess, seen as restricted diffusion, and the enhancement rim is thin medially but thicker towards the edge, towards the cortex. Thin medially but thicker towards the edge. But generally it is smooth, of uniform thickness, smooth outline, and exterior and interior. Edema is usually surrounding the abscess, and the contrast enhancement is usually intense. This is due to mastocytitis with large abscess formation and air. So this is autogenic from the ear. Destruction of vitreous bone, destruction of the mastoid bone, air cells, thus air comes in. This is the multilocular, ruptured into a ventricle, and thus we have associated ventriculitis. The ventriculitis caused disturbance of CSF flow, thus there is diffuse dilatation on the contralateral side, and here is a typical appearance of a multilocular abscess with the smooth, rather well-defined outline, thin medially, thick towards the cortex, surrounded with edema and buckling. Abscess with mycotic aneurysm, and usually mycotic aneurysm are usually multiple, but here we have 1 or 2, and this is the abscess multilocular, showing this thick, enhancing uniform wall with massive edema surrounding, and there is associated hemorrhage. due to mycotic rupture, mycotic aneurysms. Abscess with frontal empyema. This is the abscess, and then these are the developed frontal empyema. Collection under tension, frontal empyema. The enhancement, look to the enhancement, is similar to that smooth one of the abscess. Now come to meningitis. What we have discussed is cerebritis, and we have mentioned complications of the meningitis. But meningitis in children and in infants could be acute pyogenic, could be due to viral, and usually it comes with epilepsy and headache, concurrent otitis, pharyngitis, sinusitis, and usually there is empyema and abscess formation or ventriculitis. All complications we have mentioned can be seen. Now here we have bilateral subdural empyema as seen in T1 weighted images with contrast, enhancing margins, and this is the start, enhancing meninges, and these are showing the similar changes. Of course, this group is different from that group, and see here the empyema on both sides. In CT, there is some minimal changes in another case, but there is definite ventriculitis and hydrocephalus. So meningitis can result in empyema, can result in hydrocephalus, and may result in abscess. Here is with empyema again, start of meningitis seen as hyperemia, and here start of the empyema, and here the final appearance. We have it. There is definite collection enclosed in these displaced meninges with definite hyperemia and enhancement of the meninges around. What is empyema? It is an extraaxial collection, could be subdural, could be epidural, but subdural is more than epidural, could be enhancing, encapsulating membranes, enhancement usually after 1 to 3 weeks. Usually it is supratentorial, potentially lethal, may progress rapidly with should be treated as neurosurgical emergency, because it might lead to it may produce ischemia. Now salmonella meningitis with empyema, irregular empyema, irregular bilateral, irregular empyema with definite pressure changes, empyema with superior sagittal thrombosis. This is empyema, and this is the thrombosis with hemorrhage and hemorrhagic infarct. Here with multiple infarcts, bacterial meningitis resulting in ischemia. Here without parenchymal swellings, but here with diffuse bilateral widespread parenchymal swellings. This is usually seen as a complication. So we have now parenchymal swelling, infarcts, sinus thrombosis, meningitis. Meningitis can produce all of these, but beside it can produce sinus thrombosis, hemorrhagic infarcts, and it also can produce an abscess, and of course hydrocephalus if there is ventriculitis. So bacterial meningitis is a dangerous condition, and if there is empyema, this should be treated surgically, and it should be treated as a surgical emergency. Bacterial meningitis resulting in diffuse encephalitis and bilateral hydrocephalus. This is the start. It is a hemicerebral, and then here it is involving all meninges and resulted in obstruction of the exit foramina. So we have hydrocephalus. Enhancement. This is enhancement in all meninges. Enhancement in all meninges. Bilateral empyema with multiple infarcts, and some are seen as hemorrhagic infarcts, and this is enhancing margins of the empyema on both sides. A subdural collection. Here it is. This is empyema again. Why this is empyema? Because there is restriction. It behaves as an abscess. There is restriction on diffusion. It is behaving like an abscess. See this one. This is subdural empyema behaving as an abscess. Bilateral epidural with subcutaneous collection and diffuse hypoperfusion bifrontal. Streptococcal meningitis is usually seen with massive infarcts. Streptococcal meningitis with massive infarcts, massive encephalitis, and infarct formation with hemorrhage. Streptococcal meningitis with massive infarction of the cerebellum. So if you have any suspicious meningitis, please consider infarcts and cerebral or cerebellar hypoperfusion. This is ventriculitis with hydrocephalus, and it's showing as fluid level, sediment of fluid here, and this is the enhancing margin of the ventricle after contrast. This is before contrast, and this one is after contrast, showing the smooth, well-defined enhancement of the wall behaving like an abscess. Ventriculitis with sequelae leading to finally multiple epidural collections which are enhancing, behaving like an abscess. Ventricular dilatation due to obstruction of the exit foramina, and the start was just hyperemia, diffuse hyperemia, and the net result is the diffuse cystic encephalitis. Diffuse cystic encephalitis. Diffuse cystic encephalitis and bilateral subdural empyemas. Some are with contrast, and one is a collection. CSF collection is not with contrast. Thank you.